Here are my disclosures, same as yesterday. So remplissage is a tenodesis of the infraspinatus and posterior capsule into the Hill-Sachs defect to try and convert it to a non-engaging extra-articular lesion. So it's indicated for moderate to large Hill-Sachs defects associated with glenoid bone loss, probably less than 20%, because even 25% is kind of getting up there. If you have an inverted pair or 25% glenoid bone loss, then you should consider a bony augmentation procedure. To do it, there's really two options. Technically, you can do a double or triple loaded anchor in the center of the defect and then pass mattress sutures through the back and tie, or you can do two knotless anchors with a double pulley technique where you take the repair suture through the shuttling suture of each other and then cinch it down. So this is what a double loaded anchor for a mattress repair looks like. Here's our Hill-Sachs defect. You want to come in and really debride that, get rid of all that fibrous tissue. You're going to put your tap in the middle of the defect, so not too close to the cartilage and not too close to the rotator cuff, but right in the middle. You want to over tap this because the bone is really, really hard for multiple dislocations. So then we'll put our anchor right in the middle. This is a double-loaded rotator cuff anchor. So you want a big, strong anchor. You're going to back your cannula out, so just outside of capsule and infraspinatus. And then I come in with a retrograde suture passer, so I'm going to make separate penetrations at about the same level of the anchor to come through infraspinatus and capsule. So you're going to place this 2 mattress sutures for this one, or 3 if you use a triple-loaded anchor, and then you tie it down. So we'll tie the first mattress and then tie the second mattress, and that's going to cinch the capsule and infraspinatus into the defect to fill your defect. Second option is to do 2 anchors with a double pulley technique. So here's our defect here. I'm going to speed this up just a little bit here. So come in and debride it, and then take your drill guide for your anchor and make a separate penetration through the capsule. So again, try and be in the center of the defect here. So these are 2 knotless anchors. So we're going to place 1 anchor, come out with your drill guide, and then you're going to make a separate penetration through the posterior capsule for your second anchor. So there's the first one. Second one comes in through a separate penetration about 1 centimeter or so apart. And you're going to put your second anchor in at about the same level of the defect. And then you take the repair suture from each anchor and shuttle it through the shuttling suture of each other, and then you cinch it down like horse reins. So as you pull on each one here, it sucks it right down in. I tie them blind. I don't go up to the subacromial space to look. Some people do. So that finishes the remplissage there. So the order of the steps is important because if you do the remplissage first, it's hard to get down to 6 o'clock on the glenoid. If you do your whole Bankart repair, then it closes down the space and it's hard to do the remplissage. So there's really, I think, 2 options. Option number 1 is you place your lowest glenoid anchor. So place your 6 o'clock anchor, you can pass and tie. Then you can do the remplissage, anchor, pass, and tie, and then go back and finish your Bankart. Or option number 2 is you place your remplissage anchor and sutures first, don't tie, do your entire Bankart repair, and then come back and tie your remplissage sutures at the end. Because you'll see once you finish your Bankart, it really closes down that posterior space and it's harder to see. So this is a 24-year-old right-hand dominant male. He's a medical student. He's had 2 shoulder dislocations, 1 playing basketball, 1 playing water polo. He's got good range of motion, but anterior instability, especially up at 90-90. His x-rays look pretty good. So you can see there's no loss of the anterior sclerotic line. On his axillary and Bernagio view, there's no real appreciable glenoid bone loss. And his MRI shows he's really got a soft tissue Bankart that comes down the front and around the bottom just a little bit. His rotator cuff is fine and there's no Hagel lesion. And even on the bottom right image, you can see there's minimal glenoid bone loss. So when you measure this out, his is on track. So his glenoid track is 27 millimeters. His Hill-Sachs defect is 15. So this is minimal glenoid bone loss with an on-track lesion. So I do this in the lateral decubitus position. I do 3 cannulas, which makes it really easy just to move your scope from the front and back so you can work from wherever you want to. This is his diagnostic scope. So he's in the lateral decubitus position. So he's got a big anterior Bankart capsular labral defect. He's already got some arthritis. You can see he's got some wear on his humeral head, so he's probably had multiple subluxations. There's his Hill-Sachs defect. Looking down, there's no Hagel, no capsular tears. His biceps and superior labrum look fine. So then I'm going to move to view, and rotator cuff is okay. So next we're going to move and view from anterior superior, which gives you a great view. Then you can really easily work on both sides. So his posterior labrum looks okay. No posterior capsular tears. His tear does come around the bottom a little bit to about 7 o'clock. Cartilage defect there.
Is this a standard scope or a 70-degree scope?
This is a standard scope, 30-degree scope. And there's his anterior defect. So he's got some glenoid bone loss, and there's a piece of bone in with his labrum. And it's almost like a ALPSA lesion. He's healed down kind of medial there and scarred in. So his labrum goes around, his tear goes around the bottom, and his labrum's healed pretty medially. So I think a big part of any soft tissue repair is mobilizing that labrum. So first we'll come in with an elevator, peel the labrum and the capsule off the medial glenoid neck, and try and take it down around the bottom. So we'll free all that up, and then come in with a shaver. And you want to get rid of all of those soft tissue adhesions until you can clearly see the muscle of the subscapularis, which totally mobilizes your labrum and allows that labrum to float back up. So then when you look back across, now his labrum is allowed to float back up for the repair. So in this case, one of the biggest changes I've probably made in the last 5 years is always starting with a posterior anchor. So a 7 o'clock portal, and I put my first anchor either at 7 o'clock or 6 o'clock. So we put an anchor at 7 o'clock here. I use oblique mattress sutures, which shifts the labrum up and keeps the knots off the glenoid face. So we start in the back, then we come to the front. So now this is a 5 o'clock anchor. So double-loaded anchor, and again use mattress sutures. So we'll pass our sutures. One goes really through the capsule and around a bone fragment if it's there. The second one just goes through labrum. So then as we tie that, it starts to shift things up. So that's my inferior repair. Then we go to the remplissage. So I put a double-loaded anchor in the defect, pass sutures through in 2 mattress configuration like I showed before, tie that down. So now the remplissage is done, and then go back to the Bankart to finish it. So did 2 more anchors in the front at about 4 o'clock and 2 o'clock. So we've got 3 anchors in the front, 1 in the back, plus 1 for the remplissage. So we've recreated that soft tissue bumper, retensioned our ligaments, the head is centered, and filled in his Hill-Sachs defect with the soft tissue there. So when we looked at our series, we found that this technique works well. Yeah, Joe. Anterior superior, the whole time. Yep. So the whole time scope is anterior superior.
And Mike, do you do anything different with regards to arm position when you're actually working in the Hill-Sachs? Meaning, do you release traction? What are some tricks with regards to, do you have an assistant translate the humerus forward? What's your kind of strategy to work in that space?
If you do it first, then you've got a great view of it, and they can see it just by rotating the arm. You can just have your assistant rotate the arm to bring it a little better into view. And what I've gone to doing more now is putting in an anchor, passing the sutures, not tying, putting the cannula back in, doing the whole labral repair, and then just tying the remplissage at the end. Because if you do it first, it's just right there. It's so big. And just by rotating the arm, you could translate the humerus forward a little bit if you need to. Another trick, a tip that I just heard that I haven't tried yet, is if you do your remplissage first and tie it, you can leave the sutures long and then have your assistant pull on the sutures to translate the humeral head back. I haven't tried that yet, but it sounds interesting. So when we looked at ours at Tulane, this is a good technique for primary surgery. However, if it's done in the setting of a revision with a failed previous Bankart, we had a 36% failure rate. So for us, it's probably better to do it as a primary surgery. Overall, in the literature, these are review studies that showed a recurrence rate with scope Bankart plus remplissage failure rate between 5 and 10%. It's important to remember you can lose some external rotation, not a lot, but probably 5 to 10 degrees of external rotation overhead. So you want to be careful probably with an overhead athlete like a thrower or a quarterback. So I think overall the recommendations for this are minimal glenoid bone loss with an engaging lesion, or moderate glenoid bone loss with an on-track lesion. Anything other than that, you probably want to do a bony augmentation procedure. I think one of the best ways to prevent bone loss is prevention, so consider surgery after 2 or 3 dislocations. Don't wait till they've had 20. In summary, I think what you do depends on the glenoid track, and if it's an on-track or off-track lesion. This, I think, is an acceptable procedure for 25% or less of glenoid bone loss. 30% is probably really pushing it. Greater than 30% Hill-Sachs defect, you may want to consider a bony augmentation. Thank you.